We'll go ahead and get started again. We're going to talk about a couple of different things. We're going to talk about hypertension and really try to guess what type of questions might be asked. And then same thing with hyperlipidemia. We'll kind of do some updates on things as well. So I think the first key thing on hypertension is there's been a lot of movement around goals for what we're treating in patients with hypertension. And the most recent AHA-ACC blood pressure guidelines um, really came down to patients with out-of-office daytime blood pressures greater than 135 systolic, 85 diastolic, and then patients with an out-of-office blood pressure of over 130 and over 80 diastolic if they are high risk. So the average person without lots of risks, 135 over 85 is sort of the place of treatment. In patients that are higher risk, and this really came out of the SPRINT study, being much more aggressive, 130 over 80, pushing treatment, anything above that. And defining high risk is one of the following: cardiovascular disease, diabetes, chronic kidney disease, 10-year cardiovascular risk greater than 10%. So that's many, many, many of our older patients, because most of them end up having a 10-year cardiovascular risk greater than 10%. So the question comes up, well, wait a second, does it make sense to treat people that are, as they get older and older and older, because it may take a long time to get a benefit and there are a lot of side effects and things like that? And the evidence from the SPRINT study really showed that we should be treating our patients that are older with a more aggressive approach. 34% lower rate of fatal and non-fatal major cardiovascular events, 33% lower rate of death from any cause, benefits similar regardless of frailty status. That was a surprise. Intensive therapy is cost effective, and generally the therapy is well tolerated. And the time to benefit was acceptably short, kind of looking at 18 to 24 months. So you're not looking at it, you need a 10 or 15 year aggressive treatment to get the benefits. You can get it relatively soon. A 68-year-old man with hypertension is seen in follow-up. His blood pressure in clinic is 150 over 96, pulse of 80. Blood pressures last year were all 130 over 80 or less. He gets multiple home blood pressure readings, which are all over 150 systolic and 90 diastolic. His past medical history is hypertension, depression, prediabetes, bilateral collarbone fractures that occurred 6 weeks ago. Medications are lisinopril and chlorthalidone. What is the most likely cause of his worsening hypertension? Is it renal artery stenosis, hyperaldosteronism, pheochromocytoma, medication use, or Cushing's syndrome? So with this patient, my first concern would be he was well controlled before and suddenly he's lost control. I mean, one thing would be non-adherence. I didn't put that on the list here. But the other thing would be, is there something happening that's messing up a treatment plan that worked before? And so I think D is the right answer. And what's happened with this guy is he's been taking NSAIDs. Ever since he fractured his collarbones, he's been taking NSAIDs, and NSAIDs can really have a negative effect on the blood pressure lowering effect of lisinopril and diuretics. So ACEs, ARBs, diuretics are really affected by taking NSAIDs. So I think that's probably what's happening here. We didn't give you a lot of other clues. We didn't give you a really low potassium or something. We didn't give you weight change. We didn't really give you anything else. So the real clue here is it kind of happened fairly suddenly, and something else happened with him. And just always be suspect on a medication messing up already controlled hypertension. I kind of divide the world into common causes of secondary hypertension and uncommon causes. And in medical school, I was taught all the uncommon causes, the things I've seen once in a while. But what I see all the time is things like sleep apnea. Patients with untreated sleep apnea are hard to treat for their hypertension, or they may develop sleep apnea over time and then their hypertension worsens. NSAID use, as we discussed, and this is such a problem with ACEs, ARBs, and diuretics. Are they taking another medication that's causing hypertension? Are they taking medicinal licorice? Did they start on venlafaxine? Did they start on an oral contraceptive pill? Recreational drug use, amphetamines, cocaine, as well as both alcohol withdrawal as well as excessive alcohol use. These are all things that can drive blood pressures up. These are the common things. Then we got the uncommon stuff. We got causes of secondary hypertension like fibromuscular dysplasia, renal artery stenosis, pheochromocytoma, Cushing's syndrome. And there are some pearls and little things that can help us on the boards figure some of these out. Fibromuscular dysplasia, almost always in women. They may have carotid disease as well, and bruits. Bruits in a young person, there shouldn't be atherosclerotic bruits, so that might suggest this diagnosis. Renal artery stenosis, individuals who develop hypertension at a increased age. They weren't hypertensive when they were in their 30s, 40s, and 50s, which is when most people with essential hypertension develop hypertension. Now they develop hypertension in their 70s. If they have other cardiovascular risk, renal artery stenosis is a very reasonable to think about. Pheochromocytoma, hypermetabolic condition, headaches, sweating, weight loss, tachycardia. The pearl is these patients get orthostatic hypotension. They may be hypertensive, but they have orthostatic hypotension when you measure it. And then a very favorite board question over the years has been somebody who is hypertensive going into surgery and then bottoms out their blood pressure during surgery. That's because patients with PHEOs have a decreased intravascular volume, so that when they get vasodilated, with anesthetics, they have a low vascular volume, they can actually drop their blood pressure. A 47-year-old woman presents for follow-up of elevated blood pressure. She had a blood pressure of 160/90 at her last clinic visit. Her average blood pressure of 20 home readings is 158/92. What do you recommend for treatment? Lifestyle modifications, chlorthalidone, lisinopril, metoprolol, or telmisartan amlodipine? Okay, so very good. 56% of you chose the combination therapy, which is the right answer here. Now, lifestyle modifications is sort of a sneaky one because, sure, we're going to talk to her about lifestyle modifications, but we're not going to get her blood pressure anywhere near where it needs to get with lifestyle modifications. We're going to need to use medications too. And what we have in our most recent guidelines is good direction on using two-drug therapy when people's blood pressure is high enough. And we'll talk about that in a second. What are the lifestyle modifications that have evidence of benefit for hypertension? Dietary salt restriction, potassium supplementation. Individuals who are overweight, losing weight can have a very significant effect. The DASH diet, if people will adhere to that, can lower the blood pressure. Limiting alcohol and doing regular exercise. These are all good things to do, and people doing all of them, that's great. That's wonderful, but it's not going to drop the blood pressure 20 points that we need to do it. So this is from the most recent guidelines. Initial combination antihypertensive therapy with two first-line agents of different classes is suggested in any patient whose blood pressure is more than 20 millimeters systolic or 10 millimeters diastolic above their goal blood pressure. And so this patient was way up above that, so appropriately you chose two-drug therapy. A 60-year-old woman presents for follow-up of hypertension. She's been taking medication, lisinopril, for the last 3 months. Her most recent outside blood pressure readings are 156/94, 150/96, 158/92. Past medical history, type 2 diabetes, GERD, depression. Meds are lisinopril 20 milligrams a day, omeprazole 20 milligrams a day, sertraline 50 milligrams a day, metformin 500 milligrams twice a day. What do you recommend for her? No changes in therapy. Increase her lisinopril to 20 milligrams twice a day add metoprolol 100 milligrams, or add amlodipine 5 milligrams. Yeah, we want to add amlodipine. We want to get a second drug on board. This is really a similar question to the last one, which is she's going to need two drug therapy. And when I was in medical school, I was taught you start a drug and you ride that horse to the end. You push that dose to the highest dose. And there is so much evidence now that that isn't useful. Um, Meta-analysis of 11,000 patients from 42 trials. What they found was you get a five-fold improvement in blood pressure. In other words, your lowering of blood pressure is 5 times higher when you add another drug than when you raise the dose of a single drug. So in general, we will add a second agent. The one category of drug where you probably get the most benefit by increasing the dose are dihydropyridines, drugs like amlodipine. But certainly we're not going to want to double a ACE or double a ARB if they're already at a standard dose. Pushing to the high dose is going to give almost nothing. Increasing the dose of diuretic might make a 2 or 3 millimeter difference. It's not going to make a 20 millimeter difference. The other thing we know is most people who have hypertension are going to require more than one drug. 75% of all patients with hypertension require more than one drug to get where we want them. So when we use combination therapy, we've traditionally used an ACE plus a thiazide diuretic. That's a very famous and commonly used one. Can be very, very effective. You can make that combination better if the patient will buy into salt restriction. ACE amlodipine combination may even be better for patients who have diabetes and increased cardiovascular risk. There's one study where they had a better outcome with that than with the ACE diuretic. But ACE diuretic, ARB diuretic, ACE or ARB with amlodipine, those are nice combinations. To give you an idea of how much of a blood pressure drop you can get with combination, this is a study. These are studies from Europe using a ARB that we do not use, as azilsartan, but combining it with chlorthalidone or combining it with hydrochlorothiazide, you saw about a 30 drop. It was a little better with chlorthalidone than it was with hydrochlorothiazide, but still, if I can drop systolic blood pressure 30 points, I'm going to be pretty happy with that. So again, when you get somebody at 160 systolic, go ahead and start them on a combo. Start them on a combination of an ARB and a diuretic or an ACE and a diuretic, or you want to do amlodipine plus an ACE. That's fine, but get them on two drugs. A 58-year-old man is seen for treatment of hypertension. He has not ever had good control of his hypertension since treatment was started 2 years ago. He has been taking medications faithfully, amlodipine and atenolol, clonidine, and losartan. On exam, blood pressure is 200 over 106, pulse is 55, BUN is 30, creatinine is 2, sodium is 137, potassium is 4, ECG shows LVH. What would you recommend? So we have a 58-year-old who's been taking their meds dutifully, not missing anything, and on 4-drug therapy. What do we do now? Increase amlodipine from 10 a day to 10 twice a day. Increase losartan from 50 BID to 100 BID. Add hydrochlorothiazide 12 and a half a day. Add hydrochlorothiazide 25 a day, or add furosemide 40 milligrams BID. So what we want to do here is put him on furosemide. We want to use a loop diuretic because of his chronic kidney disease, his renal insufficiency. we're probably not going to get as much of an effect from a thiazide diuretic, and the gout risk will be much higher um, than if we used hydrochlorothiazide without in a patient without renal insufficiency. So I think this one we're probably going to do a loop diuretic. We usually don't use loop diuretics as blood pressure meds, except in our renal failure patients. And you do have to diagnose, you do have to treat it twice a day. Go ahead and give it twice a day because of the short half-life of furosemide, really only lasting 6 hours. So would go ahead with a furosemide is probably the better option. Now, when we see people with resistant hypertension, our first, second, and third thoughts are they're not taking their meds. And why is that? Well, because most of our patients don't take their blood pressure meds how we prescribe them. This is a study of patients referred for renal denervation therapy for refractory resistant hypertension. And so these are the worst of the worst. These are people that are sent for a procedure because meds just aren't working. And so they're sent for a procedure. And what they did is they measured blood levels of all antihypertensive drugs on all these patients, and they found 80% of the patients had fewer medications detected than prescribed. So the patients with the worst refractory hypertension in that group, you think would be the most worried because they're agreeing to let somebody mess around with their kidney. 80% of them weren't taking their meds as prescribed. So we know this is real. We need to push hard on this. We need to check pharmacy records. We need to really talk to the patient, talk to family members, do whatever we can to see if adherence is the problem. A 55-year-old woman presents with persistent hypertension. She's been taking chlorthalidone, lisinopril, amlodipine, and metoprolol. Blood pressure today is 158 over 96. Outside readings are similar: 160 over 96, 154 over 94, 166 over 98. And she is taking her meds. You check pharmacy records. She's filling them every month, doesn't miss anything. So she's listening to what you're saying. Sodium's 134, potassium 42, BON 12, creatinine 1. What do we recommend? Replace chlorthalidone with furosemide, add diltiazem, add clonidine, add spironolactone, or switch amlodipine to minoxidil. Which of these are we going to do? So 63% of you chose spironolactone, absolutely correct. And we have a lot of this highlighted in the most recent guidelines. Um, what we're treating with spironolactone are patients who have primary hyperaldosteronism. And the worse the hypertension, the more likely that's going to be true. So when you get people on 4 drugs, you have people sent to hypertension clinics, up to a quarter of them end up having primary hyperaldosteronism. It's estimated to be maybe 5 to 10% of people with hypertension. And one of the pearls you're always taught is you look for hypokalemia, but over half of these patients don't have hypokalemia. Now, part of that reason is a lot of these people we see when they're on an ACE or an ARB, they're already treated with drugs that have an effect on potassium handling, but just don't get too wedded to the idea that everybody with hyperaldosteronism has to have a low potassium. If you want to do a workup, you can do plasma renin activity and aldosterone concentration. And patients who have an abnormal result there, you can do a CT to see if they have adrenal hyperplasia. Most of the time, we just go ahead and treat these people with spironolactone and see how they do. Pretty amazing data here. Average blood pressure reduction 17 to 20 systolic, 4 to 9 diastolic with just spironolactone. Remember, we had a 30-point drop when we did 2 drugs. Here's one drug that will drop up to 20 systolic, and these are generally given to patients who are hard to treat. They're already on other drugs. In a study of 175 patients with refractory hypertension on a mean of 4 blood pressure meds, addition of spironolactone resulted in the lowering of the blood pressure by an average of 16 systolic, 9 diastolic, with half of them achieving goal. So this is sort of our miracle drug in the patients who nothing else is working to. Now, it doesn't work in everybody, but it certainly can be remarkably effective in some of your patients. This is a study that looked at aldosterone levels in patients with and without hypertension. They looked at their aldosterone levels, and then they recorded in those with hypertension how many drugs they were on. And they found all the people with hypertension had higher aldosterone levels than those who didn't have hypertension. And the more antihypertensive they were on, the higher their aldosterone levels. So the people that were on no drugs, 4.8, all the way up to 3 drugs, 7.9. A 64-year-old woman presents for follow-up. She's had a past medical history of osteopenia with a T-score of minus 2.3 at her hip and GERD. She has had 3 outside blood pressure readings of 160 over 90, 158 over 88, and 164 over 92. Today in clinic, her blood pressure is 158 over 86. Her blood pressure a year ago was 154 over 88. She's on omeprazole and vitamin D. We would want to treat her with 2 drugs. So I'm gonna give you amlodipine. You're just gonna put her on amlodipine, and what other drug would be the preferable drug to put her on? Chlorthalidone, lisinopril, metoprolol. Those are the 3 choices you're going to get. We don't want to pick A because we're not going to monitor her blood pressure. It's too high. But which of these is the best to give her? Chlorthalidone, lisinopril, or metoprolol? So I think a combination for her of amlodipine and chlorthalidone would be great. And part of that reason is because a very important part of that is she has osteopenia, and we may get a twofer here. We may get something else beneficial. And we know that in patients who are on thiazide diuretics, they trend to have a higher calcium, and they trend to not excrete much calcium in the urine. That's why we give people thiazide diuretics when they have kidney stones. This is a meta-analysis of 5 trials of 756 patients who were on thiazide. Serum calcium levels were higher in the thiazide-treated patients with a difference of 0.33, and urinary calcium was lower in the thiazide-treated patients. Well, this doesn't prove anything, right? Well, this study is pretty impressive. 11 eligible cohort studies involving over 2 million participants. Thiazide diuretic users as compared with non-users had a 14% reduction in the risk of all fractures and an 18% reduction in the risk of hip fractures. Their reduction only lasted as long as they were on the thiazide diuretic, but there seems to be some bone protective effect with thiazide and thiazide-like diuretics like chlorthalidone. Okay, we're going to now move from hypertension and move to talking about lipids. A 48-year-old woman with hypertension presents for annual follow-up. Her last lipids were checked 5 years ago, where she had a total cholesterol of 190, LDL cholesterol, I think 135, HDL of 45, triglycerides of 100. Meds, nifedipine and chlorthalidone, exam, blood pressure 140 over 60, pulse of 80, chest is clear, cardiac exam is normal, except for 2+ edema. Now she has a total cholesterol 255, an LDL of 170, an HDL of 40, and a triglyceride of 160. So we've had this rise in LDL cholesterol. What's the most appropriate next step? Start pravastatin, start atorvastatin, start ezetimibe, check a CMP, UA, and TSH, or check a BMP and estrogen level. Okay, so I think the right answer here is to do some labs. She's young, she's 48. If you plug everything into cardiac risk calculator, her risk is less than 7.5%. But more importantly is when you see a real shift in LDL cholesterol, when you see a cholesterol, go up 30, 40, 50, sometimes 100 points, let's try to think about, is there some underlying cause? Most people it probably won't be, but it's worth it as a first step. And in here, we don't need to race into getting her on a statin. So let's go ahead and check a CMP, UA, and TSH. And the reason we do that is we look at the different causes of secondary hyperlipidemia. Nephrotic syndrome certainly can do that. We pick that up in our UA. Hypothyroidism, TSH would help with that. And then a CMP, we're going to see any cholestatic liver disease. So we can get a pretty good handle on these different causes of secondary hypertension. The other thing secondary hyperlipidemia. The other thing that's important is diabetes. Uncontrolled diabetes, triglycerides go up, LDL cholesterol goes up. So if maybe we make a diagnosis of new diabetes, and in our patients with diabetes, when their lipids go up, we're certainly going to treat them because they have diabetes, but we also want to control the diabetes because that's going to affect their cholesterol as well. A 61-year-old man with hyperlipidemia, type 2 diabetes, and a family history of early MI had a hospitalization for unstable angina and received a coronary stent last week. He is taking 40 of pravastatin, clopidogrel, aspirin, and metformin. His labs, A1C is 6.5, total cholesterol 210, HDL 45, LDL 119, triglycerides 183. What is most appropriate treatment? Bump his pravastatin to 80, switch him to 80 of atorvastatin, put him on atorvastatin at 80 and niacin 1,000 or a niacin 1,000. Yes, and this person who now has coronary disease, known coronary disease, we want to get them on a more potent statin. And we certainly don't like the LDL of 119 in somebody with active coronary disease. We really want to get his LDL cholesterol ideally below 70. Whether we're going to get that with 80 of atorvastatin remains to be seen. It's possible. We may need to add ezetimibe to that, but we're going to be targeting a much lower LDL cholesterol and move him from the moderate potency statin to a high intensity statin, because he had previously been on primary prevention with his diabetes. Now he's going to be on secondary prevention. A 70-year-old woman presents her primary care visit. She has no symptoms, past medical history, hypertension, GERD. She's a non-smoker, blood pressure 120 over 70, pulse is 66, A1C 5.2, BUN10, creatinine 1.1, total cholesterol 190, LDL 135, HDL 42. What do you recommend? Diet and exercise, recheck cholesterol, fenofibrate, pravastatin, atorvastatin, or no intervention? Okay, I think the right answer here is putting her on pravastatin at 40. Um, so we constantly have to decide when and we will put people on statins. And we have our cardiac risk calculator to help us talk to patients. And the U.S. Preventive Task Force has weighed in at 10% of cardiovascular risk over 10 years. And the AHA has said 7.5%. So we kind of decide between those, shared decision making. And you're not going to have that calculator, or you're not going to have it. You're going to have to try to figure it out on your own on any exam. And I will tell you, at 65 with one cardiovascular risk factor, your risk is going to be over 10%. So this is a 70-year-old patient, and they have a cardiovascular risk factor. So they have hypertension. So this patient would meet criteria to go ahead and get them on medication. So that's where that came from. I would put them on start on a lower dose, 40 milligrams of pravastatin, make sure they tolerated it, and see how we do with her lipids in the future. Hopefully we'll be able to get her under 100, which would be kind of her target for that. So the AHA risk calculator for this patient, she has 11.5% over the next 10 years. So we want a low to moderate intensity statin. And, quick and dirty way to do this is over 65 with one or more risk factors. You're going to have at least over 7.5%. And most of these people will have over 10% risk. The U.S. Preventive Task Force has weighed in, and, over 10%. The AHA is over 7.5%. While undergoing evaluation following a hysterectomy, a 50-year-old is noted to have total cholesterol of 245, HDL of 56, and a triglyceride of 645. She has an A1C of 5.6%. Past medical history, migraine, hypertension. Her exam is normal, and her medications include propranolol, hydrochlorothiazide, and oral estrogen. What do you recommend now? No change in therapy, add niacin, add gemfibrozol, replace propranolol and oral estrogen. I would do D. First of all, I mean, does she have like 100-year-old doctor or something? Something's going on there. She's on propranolol, probably for migraine headaches, but she's now getting hysterectomy. She's older. The oral estrogen piece, if you're going to switch, you probably switch it to a transdermal estrogen. You would replace that. So probably get her on a maybe a little bit better migraine prophylaxis regimen. Get her away from propranolol because it's probably raising her triglycerides. The oral estrogen is probably raising her triglycerides, and that would be my first pass at this. She's over 500. She could get a bit higher than this. So I'd probably do that as a fairly simple thing to do. I probably wouldn't start treatment with, I definitely wouldn't do niacin. Fibrates, she's high enough that you might think about that, but I wouldn't do it when she's got a couple of meds that are the problem. So what can elevate triglycerides? Moderate elevation, 3 to 800. Non-fasting state is the most common time we see this. Medications, estrogen. When we use transdermal, we see less of this. Beta blockers, protease inhibitors, Accutane, some of the neuroleptics. People who have hypothyroidism run into problems with this, and then insulin resistant and diabetes. The severe elevations are when we see it with familial hypertriglyceridemia and some medicines. I mean, I have an HIV clinic, and back in the days when we were using full dose ritonavir, I got somebody's triglycerides up to 3,000 with full dose ritonavir. Same types of elevations have been infrequently seen with some of the neuroleptic medications. So let's talk about a few of the different cholesterol lowering options. Ezetimibe is sort of a second line. It's an add-on we use a lot when we don't get to where we want with our statin alone. It inhibits cholesterol absorption of the brush border, usually get a 15 to 20% reduction in LDL. It's approved for use alone or with statin. It's used alone sometimes in statin intolerant patients. When you combine it with a statin, there's a little increased risk of muscle pain and myopathy. And we generally don't use this with gemfibrozol. That's something that's recommended not to do. Bile acid sequestrants are not used for cholesterol lowering anymore. They can lower it 10 to 25%, but there's really not a lot of outcome data on that. And I think generally we go through a different algorithm now where we don't use bile acid sequestrants for lowering LDL cholesterol. The main thing that we use it for is to treat bile acid salt diarrhea that we get after we remove people's gallbladders. Cholestyramine is incredibly effective for that. Niacin, pretty much just say no. It has a lot of number of things that are positive. Reduces LDL, it raises HDL, it reduces triglycerides. My goodness, this is a wonder drug. The problem is niacin has a lot of side effects. Flushing, you have to slowly go up on it. And the bottom line in the bigger studies that have been done, it really had no effect on mortality, really didn't benefit when you add it to a statin, and it increases the risk of gout and worsening diabetes. So really, in 2025, niacin doesn't have a role. Fibrates, we use them when we're treating people with very, very high triglyceride levels because it can reduce triglycerides by 50% or more. We don't use it as an adjunct to try to help coronary disease. Back years ago, we thought that it would be helpful along with a statin, but we just learned that it just causes more rhabdomyolysis when we do that. Familial hypertriglyceridemia is probably the main place we use fibrates, or if we have to keep people on a medicine that will raise their triglycerides and raises it over 500 or to a more dangerous level, we might use it. But it's not really there for cardiovascular protection. Fenofibrate is the best if you have to combine it with a statin because it has less drug interaction compared to gemfibrozil. A quick comment on marine omega-3 fatty acids. Icosapent is a prescription omega-3 fatty acid that is FDA approved for use with high triglycerides in patients with the highest cardiovascular risk. Some people will prescribe this for that. I think it's got a limited market, a limited group of people you'd use it for. But one of the things I wanted to comment on about both icosapent and especially over-the-counter omega-3 fatty acid ethyl esters is that the major concern when you use these is it can increase the likelihood of atrial fibrillation, that there have been several studies that have gone, retrospective studies, and really are pretty well done. And actually, warnings in Europe, they do warn about the use of omega-3 fatty acids in people who have had AFib because it may increase future AFib episodes. So, what do I do with my patients? I don't generally recommend over-the-counter omega-3 fatty acids for cardiovascular protection because there really isn't a lot of data that supports it, and there may be some risk to atrial fibrillation. A 68-year-old man presents for follow-up after recent MI. He's had 4 prior MIs over the last 12 years. He has had a 3-vessel CABG and 2 stents placed. He quit smoking after his first MI 12 years ago. Blood pressure ranges from 110 to 130. Diastolics are all great, so his blood pressure control is pretty good. He's on irbesartan, aspirin, atorvastatin, ezetimibe. Total cholesterol is 150, HDL is 36, LDL is 78, triglycerides are 200. What is the best treatment to reduce his risk of reinfarction? So this guy's got quite a history, doesn't he? He's had 4 prior MIs. He's had 3-vessel CABG and 2 stents placed. So what is the best we can do to reduce his risk of reinfarction? Add chlorthalidone, add niacin, add avolcamab, or add fenofibrate? Okay, so yeah, I think adding avolcamab is the right answer. His blood pressures are quite good. It's his highest is 130, and his diastolics are getting a little on the low side. They're getting a little bit soft. So, he's down to 55 on some of his diastolics. So I think pushing the blood pressure control even more has a little bit of risk because of how low his diastolics are getting. So I think in this case, avolcamab is probably is the right answer here on what to do to try to decrease his cardiovascular risk. So PCSK9 inhibitors were initially released for homozygous, heterozygous familial hypercholesterolemia, but they now have been expanded. We use them in our highest risk patients, really to try to push the LDL cholesterol as low as we can go, certainly trying to get it below 70 of this guy, which he wasn't able to achieve with his current treatment. And then we also use it in patients who really need to be on lipid lowering who can't tolerate a statin. A patient who you do everything and they can't tolerate a statin, that's another potential indication for this. A 66-year-old woman is discharged from the hospital after an MI. Her discharge medications include atorvastatin 40 milligrams, lisinopril 20 milligrams, aspirin 81 milligrams, and clopidogrel 75 milligrams. At her follow-up appointment, she mentions that she has muscle pain and stiffness in both legs and her back. Labs TSH2, vitamin D 40. She stops atorvastatin for 2 weeks and the symptoms get better. So she went home from the hospital on a statin, ached, got on the internet, read about statins and they might ache with statins, stopped it on her own without your advice, and everything went away. She feels better now. What do you recommend for her? Restart her atorvastatin, start rosuvastatin twice a week, start ezetimibe, or start a PCSK9 inhibitor? So, yeah, I think there's several different choices here. I would do A. Um, I think I think D will be a challenge because we won't be able to get the prior authorization on it. Although, if she absolutely refuses ever taking another statin again, I think D is a very reasonable option. I think azethamide's in there, but I would try to keep her on the statin, and I would just re-challenge her with atorvastatin. And we're going to go through some of the data on that. So the first thing to know is that statins have an amazing nocebo effect. And this study was such a beautifully done study. 60 patients with a history of statin-associated muscle symptoms were entered into this trial, and they each got 4 bottles containing atorvastatin, a dose of 20, 4 bottles containing placebo, and 4 empty bottles. They then were texted each month which bottle they were supposed to use that month, and then they were supposed to keep daily symptoms on how they felt. So when they get the empty bottle, they would just look at the empty bottle every day and they'd record their symptoms, and they recorded their symptoms when they took the atorvastatin and when they were on the placebo. And there was the lowest set of symptoms. The intensity was 8 when they had the no tablet months, when they just had an empty bottle. But the symptom intensity was pretty much equal between placebo and atorvastatin. It was 15.4 during placebo months, 16.3 during statin months. So a P of 0.001 comparing each of those with the no tablet months. So taking nothing was better than placebo or atorvastatin. So what we're really not seeing here is, we're seeing just as much aches and pains with taking something where you might think it's a statin. This is a study of re-challenge where they just put the person back on the drug that they had stopped that had caused their pain. So if they're on atorvastatin, they had muscle pain, and they stopped it and the pain went away, they went to this lipid clinic which was specializing in people who were statin intolerant, and they just put everybody either back on their old statin, they put them on a new statin, or they put them on a non-statin, which was ezetimibe here. Tolerability was 71% if they gave them their same statin, 53% if they switched statins, and then 57% if they put them on a non-statin. So it seemed to be at least as good to re-challenge them. So I think that's a reasonable first step, to re-challenge them with a statin. I think it's not wrong to switch them to a different statin, but I think with one episode of statin-related muscle symptoms, we need to try other things too before we get rid of statins, because statins have our most powerful evidence. So approach to when you get a patient with myalgias on statins, check a CK, a TSH, and vitamin D, and there are reasons for this. A small percent of people on statins will actually bump their CK, so they might be having pain with a higher CK. It might be 200. Those patients truly have statin-associated muscle symptoms that are real, and they're not a nocebo effect. And you're going to have to figure that one out, what you want to do, if you want to try a lower dose or if you're just going to monitor that. But it's good to check the CK. Hypothyroid patients are more likely to have statin-associated muscle symptoms, so we want to know if they're hypothyroid. And patients who have low vitamin D levels tend to have more statin-associated muscle symptoms. So let's get that baseline labs. Then review for drug interactions, especially calcium channel blockers. Diltiazem is probably the biggest culprit. Diltiazem plus a statin, you double the area under the curve. Same for verapamil. Amlodipine doesn't double it. It's less of an effect, but it does have a little bit of an effect. So we make sure there are no drug interactions, and we stop the statin. When symptoms disappear, we restart the statin at a lower dose, or we change the statin. Then if that doesn't work, we might switch to an intermittent potent statin like rosuvastatin intermittently. The problem is there's no data to show cardioprotection with intermittent rosuvastatin. There is one study that showed most of the people could tolerate it, but that wasn't an outcome study. And then if you can't get them on a statin, your choices are ezetimibe or a PCSK9 inhibitor. Last thing I wanted to touch on is the new kid on the block, which is bempedoic acid for statin intolerant patients. This is a big study of almost 14,000 statin intolerant patients who are enrolled. So there are a lot of those people out there. In a double-blind randomized placebo-controlled trial, they got bempedoic acid or placebo. The incidence of primary endpoint event was significantly lower with bempedoic acid than with placebo, with hazard ratio of 0.87. With a good p-value, as were incidents of composite of death from cardiovascular causes, non-fatal stroke, or non-fatal MI. Side effects we need to know about with bempedoic acid are increases uric acid a little bit, so increases gout, and it can increase the risk of gallstones. There is a black box warning for tendon rupture, but in expanded access of bempedoic acid, there really hasn't been an increased risk of tendon rupture, but it still has a black box warning, I think. So anyway, think about the possibility of gout and gallstones, albeit is very low. Just a 1% increase in gout over placebo and a 1% increase in gallstones over placebo. But in such a big study, it was statistically significant. I think I'll stop there. Does anybody have any questions on the hyperlipidemia, hypertension?
Yeah, Doug, there's one question in the chat from a couple of cases ago when you were kind of talking about shared decision making for that in-between risk. And they were
Yeah.
wondering if you can comment if the boards are actually, if you think they're moving towards things like Prevent, or are they still using the pooled cohort calculators? Because that patient maybe wouldn't have officially made the cutoff. So I don't know if you have comments on that.
Yeah, I think um, and this is speculation, but I think, they're going to use a 10% cutoff for for using for doing this, because these questions were written, 4, 5, 6 years ago. So that's my guess that will be what will be done. I don't think they're going to give you somebody that would end up between 7.5 and 10%. I think it'll be a more obvious patient with multiple risk factors.
I would agree. Thank you. And then there's another question that's kind of a niche, but asking for that case with the high triglycerides after hysterectomy, thinking about intraoperative medications like propofol. If you presume that perhaps that was used during surgery, and that could that potentiate the triglyceride raising effects of the propranolol, or would that really have to be fairly prolonged exposure to propofol, like if someone was on an infusion in the ICU?
Yeah, I think if they just got it, if they had gotten that um for surgery, that would be a short-term risk. And this patient, I meant with that case was more the patient comes back for follow-up, after their hysterectomy, which is a period of time after they've healed up. But that's a good thought. We always want to think of different drugs that can do this. But the other key thing, having written many questions for the boards over the years, is don't assume something's there if it's not there. They're going to tell you the facts that are going on. They're not going to want you to assume something's happened, because there's really a pushback on that. And certainly I know with the national board, they absolutely throw out any question where we make people have to assume something, like they had surgery and they might have gotten this and it might have been. So don't outsmart yourself on some of these questions, because you guys are all really smart, and it's really easy to sort of find something rare or difficult. So unless they tell you, don't assume it's there.
That is great advice. That was all the questions in the chat. If you can
Okay.
wait a few more minutes, and otherwise you can let us know what transition you're ready for.
Okay. Well, let's see. We'll get you out a little bit early.